when you think about medical terminology, there is there's this expectation of just total precision, like engineering or something.
Right, yeah, like a perfectly mapped territory.
Exactly. You point to a bone, it has a distinct name. You point to a blood vessel, it has a highly specific, universally agreed upon name. I mean, it's supposed to be a foolproof system.
We really like to imagine that the human body is categorized with this absolute binary clarity, like it's completely immune to misinterpretation.
But then you actually look at the words we use for the human body's urinary plumbing,
Yeah.
and suddenly that precision just completely evaporates.
Oh, totally. Just falls apart.
You find yourself staring at three of the most confusing, look-alike, sound-alike words in the entire medical dictionary. I mean, pyelo, uretero, and urethro.
It is the absolute definition of linguistic muddy waters, and frankly, it's a place where, well, a single typo can change a patient's entire surgical outcome.
Okay, let's unpack this. If you are listening to this deep dive, you are someone who loves to figure out how things actually work under the hood. So our mission today is to untangle these three notoriously confusing root words, map out the physical urinary plumbing system, and figure out why this vocabulary is so incredibly high stakes for patient safety.
And to do that, the research gives us this beautifully simple baseline logic to hold on to as we take this journey. Basically, it's one basin, 2 tubes down, 1 tube out.
One basin, 2 down, 1 out. I like that.
Yeah, it's the perfect mental map for the end of urine's journey. So we start inside the kidney, where the fluid collects in a basin, and that's the pyelo.
Right.
Then it travels down 2 separate tubes, one descending from each kidney, and those are the uretero. They drop the fluid into the bladder.
Okay, the 2 tubes down.
Exactly. And finally, it exits the body through one single tube, the urethra. So basin, 2 down, 1 out.
I always pictured, medical Latin and Greek as this perfectly organized system invented by one guy in a sterile lab.
Oh, if only it were that simple.
Right. But having 2 distinct, critically important tubes named ureter and urethra feels like a massive design flaw. It just seems like a blatant setup for failure.
Well, what's fascinating here is that this isn't a modern coining error at all. It is literally an accident of shared ancient etymology.
Wait, really? So it wasn't just a bad meeting in the 19th century?
Not at all. None of these 3 roots were invented by a committee in a modern hospital. We inherited them from the ancient Greeks.
Wow.
Yeah, physicians back in the 5th to 3rd century BCE, like those in the Hippocratic school, they were just using everyday conversational Greek words to describe what they saw during dissections.
So they weren't trying to be overly academic. They were just calling it like they saw it.
Very much so. And later, figures like Galen of Pergamon kind of systematized these observations around the 2nd century CE.
Okay, so where do the words come from?
Well, the roots uretero and urethro both derive from the exact same ancient Greek verb urinin, which simply means to urinate.
I see. So it just describes the function.
Right. The ancient anatomists knew they were looking at 2 separate sets of tubes doing 2 separate jobs. But because both structures dealt exclusively with urine, they gave them essentially the same root name.
Just adding different endings, I guess.
Exactly, using the nouns Ureter and Urethra.
I mean, to them, the distinction might have been obvious, but to our modern ears, near identical spelling and pronunciation just creates a nightmare.
Oh, absolutely.
And what about the basin? The pyelo?
Oh, that one reveals just how domestic their terminology really was. It comes from the Greek word pyelos, meaning trough or tub.
A tub.
Yeah, it was literally the everyday word the Greeks used for a washing basin. When early anatomists cut open a kidney, they saw this funnel-shaped central cavity where the urine pools before draining.
And they just thought, hey, that looks like my laundry tub.
Exactly. They thought it looked exactly like the basin they washed their tunics in.
That is wild. We are diagnosing modern, complex kidney diseases using ancient laundry terminology.
We truly are. But, the idea of an organized medical vocabulary didn't even exist for a very long time. Prior to the late 19th century, anatomical terminology was just absolute chaos.
How bad was it?
Well, across Europe, medical schools were juggling roughly 50,000 different terms for human anatomy.
Like 50,000 terms. How many structures were they actually naming?
Only about 5,000 physical body parts.
You're kidding.
Yeah.
10 words for every single part.
Basically, yeah. This meant a French surgeon A German anatomist and a British doctor could be looking at the exact same organ and have absolutely no idea what the other is talking about.
Because they all had their own local names for it.
Exactly. The same body part might have a Latin name, a Greek name, a local slang name, and probably be named after 3 different doctors who all claim to have discovered it first.
That sounds like a catastrophic communication crisis.
Yeah.
Especially as medicine started becoming more globalized.
It really was. And, if we connect this to the bigger picture, it explains why the system we use today is so remarkably rigid.
They had to crack down on the chaos.
Right. The medical community realized this Tower of Babel was actually killing people. So, in 1895, the German Anatomical Society convened an international congress and published the Basel Nomina Anatomica.
Sounds like a massive undertaking.
It was an incredibly arduous effort to strip away all the vanity names and regional dialects. They created the first internationally agreed-upon list of standardized terms.
The great medical cleanup operation.
Exactly, a cleanup operation that was later refined by the Terminologia Anatomica in 1998. They took those ancient Greek and Latin words and locked them into the highly structured, testable root prefix suffix system we rely on today.
So the words themselves are thousands of years old, but the tidy, modular system that forces us to memorize them is barely a century old.
You nailed it. That's exactly how it happened.
Okay, so having established how we inherited these ancient words, let's physically follow the path they describe, starting at the very top of the system with that washing basin, the pyelo.
Let's do it.
So when looking at the clinical protocols, I caught a huge misconception that I think a lot of people share. I always assumed pyelo just meant the entire kidney.
You are definitely not alone in that. That is one of the most frequent stumbling blocks for students.
So it's not the whole kidney.
No. Nephro and reno are the roots that denote the entire kidney, like the organ as a whole. Pyelo is strictly and exclusively the collecting funnel located inside the center of the kidney.
Oh, okay. So it's a specific structure within it.
Exactly. To visualize the upstream path, you have the glomerula, which are the microscopic filtering units doing the actual work of cleaning the blood.
Right, the filters.
And those filters feed into the calico, which act as small cup-like structures. And then those tiny cups pour everything into the main central washing basin, the pyelo.
That makes so much more sense. I always assumed pregnant women got more kidney infections simply because their immune systems were generally stressed.
A lot of people think that, yeah.
But reading the clinical protocols, it's actually a brilliant, if frustrating, example of mechanical and chemical changes in the body. I mean, the condition is called pyelonephritis, which is inflammation of that specific basin and the surrounding kidney tissue.
The underlying mechanisms are fascinating. It's a perfect storm of applied anatomy. Chemically, a pregnant body produces steadily rising levels of the hormone progesterone.
Okay.
And one of progesterone's primary biological jobs is to relax smooth muscle tissue.
Which makes sense for the uterus. You want that muscle relaxed so it doesn't contract prematurely.
Right. But the complication is that the ureters, the tubes carrying urine down from the basin, are also constructed of smooth muscle.
Oh, wow. So they get relaxed too.
Exactly. Under normal circumstances, they aren't just passive pipes. They actively use peristaltic waves.
Meaning they squeeze.
Yeah, they rhythmically squeeze and sweep the urine downward. That active downward flow acts as a mechanical defense, constantly flushing out bacteria and preventing it from climbing up.
So the systemic progesterone relaxes the smooth muscle of the ureters, causing those squeezing waves to become incredibly sluggish.
You got it. And then the physical component enters the equation. As the uterus enlarges to accommodate the growing fetus, it mechanically compresses those sluggish ureters against the back of the abdominal wall.
Just physically squishing them.
Yes. Interestingly, it usually compresses the right ureter more significantly due to the way the uterus naturally rotates as it expands.
So you end up with a relaxed, sluggish tube that is now being physically pinched off.
Exactly. This creates what we call urinary stasis. The fluid just sits still instead of being actively pushed along.
And still water is never a good thing.
Never. Still water in the human body is always a breeding ground. It gives bacteria, most commonly E. coli that is tracked up from the outside world, ample time to ascend from the bladder.
Just climbing right up the sluggish tube.
Yeah. They climb the sluggish ureter and set up a severe infection right inside that pyelo basin.
This highlights exactly why prenatal care protocols are so incredibly strict about screening for asymptomatic bladder infections.
Oh, absolute.
Clinicians have to catch the bacteria before it climbs that ladder. If it develops into pyelonephritis, the stakes jump to preterm labor or maternal sepsis.
Location changes the clinical stakes entirely.
But what absolutely blew my mind in the research is that identifying that location, like figuring out exactly where the basin ends and the descending tube begins, is a matter of massive, ongoing controversy.
Ah, yes. The great boundary debate of the ureteropelvic junction, or UPJ.
I couldn't believe this part.
It's wild, right? Anatomists and surgeons are still arguing over this specific transition point.
Yeah, imagine a wide funnel draining down into a narrow straw. I always assumed there was a clear biological border where one organ stops and the next begins.
You would think so.
But some older anatomy texts argue the pelvis is its own distinct organ, while modern interpretations say the pelvis is just the dilated, widened top portion of the ureter, like it's all one continuous piece of tissue.
And you might wonder why semantic pedantry over a microscopic border even matters.
Right, it sounds like an academic argument.
But it matters deeply when things break down. Consider a congenital condition like UPJ obstruction, where an infant is born with a physical blockage right at that exact transition point.
Oh, wow.
Because the fluid cannot drain into the straw, it backs up and inflates the kidney like a water balloon under high pressure. This dangerous swelling is called hydronephrosis.
And the delicate filtering structures inside the kidney can get crushed by that back pressure if it isn't relieved. So a pediatric surgeon has to go in to reconstruct it with a procedure called a pyeloplasty.
Exactly. And depending on which anatomical textbook the hospital relies on, the tissue that surgeon is reconstructing technically belongs to different sides of the pyelo and uretero boundary.
That is just crazy.
It is. That arbitrary line dictates how radiologists describe the anatomy in a scan, and it dictates the literal diagnostic codes a hospital uses for billing and legal classification.
That arbitrary line dictates our transition into the uretero, the two tubes carrying fluid down. And here's where it gets really interesting, because this particular tube is the site of one of the most agonizing experiences in human medicine, which is kidney stones.
Right. Known clinically as renal colic.
The biggest misconception is right there in the common name. People call it kidney stone pain, so you naturally assume the pain is happening inside the kidney organ itself.
It's a very logical assumption.
But the mechanism of the pain tells a completely different story.
Yeah, a calcified stone can actually sit quietly in the spacious renal pelvis basin for months or even years without causing severe agony.
Wait, really? Just hanging out in the basin?
Yep. The catastrophic pain, which patients frequently rank as the worst imaginable, often comparing it to or even exceeding the pain of unmedicated childbirth, that pain only begins when the stone leaves the basin and gets wedged in the ureter.
Because the ureter isn't a straight, uniform plumbing pipe. The research describes it more like a terribly designed water slide with 3 specific traffic jams built into the architecture.
I love that analogy. Yes, the ureter has 3 natural choke points, or anatomical narrowings.
Wait, so where is the first one?
The first is right up top at that fiercely debated ureteropelvic junction we just discussed.
Traffic jam number 1. The funnel narrows into the straw.
Exactly. Now, if the stone is small enough to make it past that initial drop, it travels downward until it hits the second narrowing.
And where is that?
This occurs exactly where the ureter has to physically cross over the large iliac blood vessels in the pelvis.
Give me a mental picture of why crossing a blood vessel creates a traffic jam.
Sure. So the ureter is a soft, pliable tube. The iliac arteries are massive, rigid vessels carrying high-pressure blood from the heart to the legs.
Okay, I'm picturing it.
When the soft ureter drapes over this pulsing artery, the physical pressure from the blood vessel flattens the ureter slightly, creating a natural anatomical pinch point.
It's like draping a soft garden hose tightly over a thick, rigid tree root.
Exactly the right visualization.
Ouch.
Yeah, and if the stone somehow navigates that arterial speed bump, it reaches the final hurdle, the ureterovesical junction.
The what now?
The ureterovesical junction. This is the spot where the ureter actually has to pierce through the thick muscular wall of the bladder to empty inside.
Oh, through the muscle.
Right. Because it travels through solid muscle, this is the tightest physical squeeze of all 3 narrowings.
So when a patient is writhing in the ER, the stone isn't just randomly scratching up a uniform tube. It is specifically lodging at one of those 3 exact choke points.
Yes, exactly.
And the pain they feel is the ureter violently going into spasms, like clamping down on the stone to try and force it out.
That's it. The pain profile is entirely dictated by that ureteral anatomy. The agony classically migrates.
Migrates, like it moves.
Yeah, it initiates in the flank, the side of the back, and as the stone grinds its way through those specific narrowings, the pain radiates downward and forward toward the groin.
So the kidney itself isn't generating that traveling pain.
No, the muscular spasms of the ureter are.
It's just wild that a tube so small can generate so much distress. So, assuming the fluid successfully navigates the ureters, it drops into the bladder, which brings us to the final stretch.
Right. The bladder is represented by the cysto or vesico root. The two ureters empty their contents onto the floor of the bladder at a smooth, triangular zone called the trigone.
The triangle on the floor. Got it.
But to finally exit the body, the urine relies on the final tube in our sequence, the urethra, which ends at the external opening, or meadow.
The one tube out. Up until this point, a kidney is a kidney, a ureter is a ureter, regardless of who you are. The anatomy is remarkably consistent.
Very true.
But the urethra is the singular structure in this trio where sex differences are completely foundational. I mean, they dictate totally divergent medical realities for millions of people.
The architectural disparity is profound. The female urethra is quite short. It's roughly the length of a thumb, or about 4 centimeters.
Okay, 4 centimeters.
And its only biological function is to carry urine. And anatomically, its external opening sits very close to both the vaginal opening and the anus.
While the male urethra is a completely different engineering schematic.
Radically different. The male urethra is roughly 20 centimeters long, running the full length of the penis.
That's a huge difference.
It is. And unlike the female urethra, it acts as a dual-purpose biological highway. It serves the urinary tract by carrying urine, but it also serves the reproductive tract by acting as the conduit for semen.
The clinical texts emphasize that it never carries both simultaneously, which requires a pretty impressive piece of biological traffic control.
Oh, nature's engineering here is incredible. The body utilizes the internal urethral sphincter, which is an involuntary ring of muscle at the base of the bladder.
So it works like a valve.
Exactly. During ejaculation, the sphincter forcefully contracts, sealing off the bladder entirely. This prevents urine from mixing with semen, and it stops semen from firing backward into the bladder, a condition known as retrograde ejaculation.
It's an automatic biological traffic light.
Right.
But that stark difference in overall length, 4 centimeters versus 20 centimeters, is the entire reason behind some massive epidemiological differences. It's wild that a simple measurement dictates who gets a urinary tract infection and who ends up with severe tissue scarring.
That short 4-centimeter runway is the primary anatomical reason women suffer from exponentially more UTIs than men do across their lifespans.
Because it's just a shorter trip for the bacteria.
Exactly. The pathogenic bacteria in the external environment simply have a much shorter distance to travel up into the bladder. It is just a matter of anatomical geography.
But that length cuts both ways. The extensive tubing in the male anatomy presents entirely different vulnerabilities.
It explains why men suffer far more frequently from urethral strictures, which is a dangerous narrowing of the tube caused by internal scar tissue.
Oh, from things passing through it.
Yeah, when you have 20 centimeters of delicate mucosal tubing compared to just 4, there is simply more surface area available to sustain an injury, harbor a localized infection, or undergo medical catheterization, and all of those things leave behind rigid scar tissue.
We've mapped the physical anatomy pretty well. We understand the basin, the 2 tubes down, and the 1 tube out.
We have.
But what's even wilder is that the clinicians diagnosing and operating on these radically different structures are relying on words that are only one single letter apart: ureter and urethra.
And this raises an important question about the modern medical system. The vocabulary is not just an academic hurdle, it is actually one of the most critical patient safety issues in clinical documentation.
So put me in the shoes of a clinician. How does an error actually happen here? If a nurse or doctor is rushing, is this just a matter of sloppy handwriting on a paper chart causing a minor hiccup?
Well, ureter and urethra are the textbook definition of ELASA terms. That stands for look-alike, sound-alike terms. But today, the danger isn't usually handwriting. It's the electronic medical record, or EMR.
Oh, because of autofill?
Exactly. Imagine an exhausted resident physician working a 3.0 a.m. shift. They need to order a procedure for a patient's kidney. They start typing URET into the computer system. The software auto-populates a drop-down menu.
And in their exhaustion, they click slightly too low on the screen.
Yes. If they mistakenly select an order for a urethral stent when they actually meant a ureteral stent, they haven't just made a typographical error.
They've picked the wrong 2 entirely.
They have legally authorized an entirely different surgical procedure on an entirely different organ.
Because one procedure is placing a tube up into the 20-centimeter structure in the penis to keep it open, and the other requires a surgeon to go all the way up past the bladder to prop open the water slide leading directly to the kidney.
Exactly. This is exactly why medical terminology courses drill these specific routes so relentlessly. And it's why sophisticated hospital EMRs are now programmed to throw hard stop alert flags when these words are selected.
I can imagine.
A wrong structure error on a surgical consent form is a catastrophic never event in medicine.
And it's not just the root words. The suffix you attach to these roots dictates the immediate urgency of the patient's condition.
Location drives the diagnosis and the treatment plan. If you take the suffix situs, meaning inflammation, and attach it to these different anatomical roots, you are describing vastly different clinical scenarios.
So if a patient has urethritis, that is inflammation of the tube out, frequently caused by a sexually transmitted infection like chlamydia. Painful, but generally localized.
Right. But if the bacterial invasion climbs higher, you diagnose cystitis, which is a full bladder infection requiring different antibiotics and evaluation.
And if that infection navigates all the way up, the water slide into the basin.
Then you have severe pyelonephritis, which carries the very real risk of the bacteria breaching the kidney's blood supply and triggering systemic, life-threatening sepsis.
Just from that latter effect.
Yes. The tiny Greek suffix attached to the end of the word tells the medical team exactly how close a patient is to a fatal emergency.
It is staggering how much weight these tiny syllables carry in modern medicine. To bring it all home, we started with a chaotic jumble of 50,000 historical terms, and we drilled down to a pristine, highly regulated system of three crucial roots.
You did.
Pylos, the basin. Ureters are the two descending tubes, complete with three agonizing traffic jams. And the urethra is the single tube out, structured dramatically differently depending on biological sex.
And distinguishing between them is just a non-negotiable pillar of safely navigating the healthcare system.
So what does this all mean for you?
It leaves us with a truly provocative thought about the nature of medicine. We naturally assume that scientific language just objectively describes physical reality.
Like we're just naming what's already there.
Right. But when we look at the great boundary debate at the uretero-pelvic junction, that arbitrary line drawn by anatomists dividing the funnel from the straw, we see that language actually dictates medical reality.
That's a huge shift in perspective.
It is. When a pediatric surgeon operates to fix a blockage, the exact billing code, the legal definition of the surgery, and the designated boundaries of the organ itself rely entirely on a decision made by a committee over a century ago.
Wow.
It reminds us that the words we use don't just describe the physical body, they legally, financially, and procedurally define it.
A typo isn't just a typo when it redraws the map of the human body. Thank you for joining us on this deep dive into the language that shapes our lives. Keep questioning the words around you and keep exploring the mechanics of how things actually work. Until next time.